Next, do we have Dr. Neroshma Shaik? Yes. She'll be presenting an interesting case of hemodialysis related.
Good afternoon, President one and all. My name is Dr. Neroshma. I am from Manukula Vinayagar Medical College, Pondicherry. I had a case report of the hemodialysis related vision loss from the anterior ischemic optic neuropathy. It is a non-arthritic anterior ischemic optic neuropathy is the most common cause of the acute optic neuropathy in the older age. It is caused mostly due to the circulatory insufficiency within the optic nerve head. The most common predisposing factors are systemic hypertension, diabetic and hypercholesteremia. The vision loss from the non-arthritic AION is a rare complication in the patients on the dialysis for the chronic renal failure. And here I am presenting a case of a 50-year-old female came with the chief complaints of the diminution of the vision in the left eye since 1 month. She had episodes of the sudden onset of the painless loss of vision during the dialysis. She is a known case of diabetic and hypertension and anemia with chronic kidney disease, and she was on dialysis for the past 1 year. And there was no history of headache, pain on extraocular movements, limb weakness, transient ischemic attacks, myalgia or jaw claudication or seizures or focal neurological defect. And the general examination to time and place, and there was mild pallor present, and there was no icterus, cyanosis, clubbing and lymphadenopathy and pedal edema. The pulse rate was 90 beats per minute, and the blood pressure was 110/60, and the respiratory rate was 18 per minute, and the systemic examination was normal. Coming to the ocular examination, that is slit lamp examination, the right eye shows the visual acuity of 6/24 with pinhole improving to the 6/12, and the rest of it was normal, and the lens shows early lenticular changes. And coming to the left eye, the visual acuity of 6/60 which is not improving to the, and the color vision is also defective in that eye, and the pupil shows grade 1 RAPD, and the lens shows. Coming to the fundus examination of the right eye, disc with a few hard X-rays in the 2 or 3 quadrants with the diabetic retinopathy picture and the grade 1 arteriolar attenuation, that is grade 1 hypertension retinopathy. And coming to the left eye, we could see the disc edema which is involving the superior half of the disc, and you 1 or 2, 3 or 4 quadrants of hard X-rays seen. And we did a visual field examination. Left eye shows that superior altitudinal defects were there, and the right eye was normal. And we made a conclusion of the provisional diagnosis of both eye moderate NPDR with grade 1 hypertensive retinopathy with left eye non-arthritic anterior ischemic optic neuropathy. As the management will depend mostly upon the to focus on the predisposing risk factor, so we went and made a workup of a few investigations. The fasting blood sugar shows 160 deciliter, postprandial blood sugar was 210, and the hemoglobin levels was 7.6, and the serum creatine was 4.2, and the blood urea was 60, and ESR and the C-reactive protein were normal. So we rule out the cause of the vasculitis, and neutrophil cytoplasmic antibody and anti-nuclear antibody was also normal. And we made a follow-up of the patient after 3 months, and it showed there is disc edema resolved, and there is mild edema was present. And regarding the discussion, NAON is characterized by the sudden, typically painless loss of vision, mostly on the awakening. The exact sequence of the events to the vision loss is still controversial. In hemodialysis patient, the intradialytic hypotension is the primary culprit in the development of the NAON. The dialysis related hypotension has a complex pathogenesis, that is insufficient vascular filling, dysfunction of the autonomous nervous system, imbalance in the vasoactive agent concentration, and the feeding during the dialysis. And the patient with the end stage renal disease are the most likely to be platelet and the endothelial dysfunction, so there will be risk of bleeding and the increased risk of the thrombi production. As our patient ESR and the CRP was normal, so we did not consider the vasculitis cause. And she's a chronic hypertension, anemia, and the end stage renal disease requiring hemodialysis for the past 1 year, and she gave the episodes of sudden loss of vision on awakening in the left eye a day after the dialysis, and we could see the disc edema which is involving only the superior part, and there is no other ocular or neurological disorder that could be responsible for the disc edema or vision loss. And we went to the past records of her blood pressure pre-dialytic and the post-dialytic, and we could notice that ambulatory blood pressure was dipping to the 55 milligrams, and confirmed the diagnosis of the NAION secondary to the hypotensive episodes following the hemodialysis. And the other cause can be nocturnal hypotension can contribute to the NaON. It effect can be exacerbated in the patient with aggressive antihypertensive therapy, especially when they are taking right before the bedtime. So my conclusion is dialysis related hypotension is an important risk factor for the development of the NaON. The both treating nephrologist and the ophthalmologist should be aware of this potentially blinding complication, and the care must be taken to prevent hypotensive episodes during the dialysis. And these are my references. Thank you.